So, any questions on the talk still now?
So I think a rule of thumb is, GLP-1 receptor agonists do not cause hypoglycemia unless you combine it with any other agent. But with any anti-diabetic, saying that there is zero risk of hypoglycemia, whether it be metformin, whether it be SGLT2, you should never say that there is zero risk of hypoglycemia. It should be warned.
Yeah, there is in non-diabetic patients, that is select trial. There are 66% of the patients were pre-diabetic, but that's a select trial where there is a significant reduction in MACE. Remember, they were extremely well controlled on a statin. Blood pressures were very well controlled, but they were just obese and had established cardiovascular disease. And in select, they showed that there is a significant reduction in MACE. Oh, it's huge, huge.
Okay, I'll start asking Dr. Anand. 45-year-old male diabetic walks in, A1C 6.4, AST ALT 70 and 80, BMI of 24. What would you do and what should be done?
Uh, Thank you, sir. Thank you for having me. First of all, I'm not an endocrinologist. I've been recently exposed to GLP analogs. I have no great exposure to GLPs. And for this patient particularly, first thing in India, we still continue to have viral hepatitis as dominant cause for liver disease. So first we would try to rule out viral infections. And if required, ultrasonography, if it can be done, ultrasonography would be sufficient enough. And if I have a platelet count, I would try to assess the FIB4 for this patient. And
Absolutely. Fair enough. Dr. Binayak, you want to continue further? If suppose, assume that viral markers are negative, we look at MSLD spectrum.
So I think I'll let Shomit answer this question because I think he can say something about FIB4 amongst Indians. So he's
Yeah.
just recently published that. So I'll let Shomit answer that.
So we did a couple of publication in Springer in scientific reports. The problem with the FIB4 is the Indian guideline, INSL, has reduced the cutoff value to 1, whereas the international cutoff value is 1.3. But what we are seeing, there are too much of false positives. Even the numbers you said, 63, 65, we are putting them to a fibroscan, they're coming absolutely normal. Because fibroscan is extremely operator dependent procedure. I have myself undergone fibroscan twice. The first operator just, it's like a click sound which happens because the sound waves hits you. And the first operator did it just twice. But you're supposed to do it at least 9 times in 10 different sites and take an average out of it. If you don't do that, then there's a huge discordance between the FIB4 score and as well as the fibroscan reports
Correct.
that you have. But I think it's a universal consensus. You need to do a FIB4. Universally, if it's more than 1.3, then it's better that you go ahead with fibroscan. Look at the cap value, which tells you the amount of fat you have, and then look at the TE score, which tells you the degree of fibrosis. Less than 8 is fine. 8 to 12, be aggressive. More than 12, refer to a hepatologist. Or
Yeah.
so FIB4 test actually in India has not been greatly validated. As you said rightly, that 65% of the population fall between 1.3 to 2.67. Only 30% to 40% will be diagnosed correctly whether having fibrosis or not based on the FIB4. So considering FibroScan, there are two machines. One from EchoSense, which I'm not endorsing any company over here, but the one which is has robust data is the EchoSense. The other one which has come from China doesn't have robust data. It can give falsely high or falsely low results.
The only idea of FIB4 is at least that set of data is widely available in all patients who walk into your clinic.
Yes,
At least to
absolutely.
start point, something else other than what is there. I agree the limitations, age criteria, all those things do exist, but we can actually have at least initiate a discussion with the patient that there is something wrong. Yeah, please. Yeah, you're audible. I'll repeat if required.
What is the incidence of, would you compare that perhaps tirzepatide has a little lower incidence of NIOD compared to semaglutide? That's the first question. And second question for you, sir. The patients with MAFLD, patients who have risk factor for cardiovascular disease, of course, injectable semaglutide is clearly showing superiority. But what about a person at the age between 20 to 30 who may not have major risk factors for cardiovascular disease? But would tirzepatide score over in such scenarios? Because tirzepatide, even at 5 milligram, has demonstrated very good weight reduction.
So as far as the NION data goes or the diabetic retinopathy goes, I think we have to wait for some kind of randomized control trial data. Everything has been studies of registries and observational stuff. So we know the inherent bias that is there in this observational data and insurance databases, and so I think we'll have to just wait for this. But I am enthused by the fact that they have not stopped focus. So I think it's probably no kind of negative signal.
So I agree with you. It looks that tirzepatide would be a better option, but you see the class A recommendation now for MSLD there are only two drugs from liver perspective. One is resmetirom, and the second one is semaglutide. So it's prudent to start with semaglutide because that's the class A indication.
Uh, this is Dr. Uwais Piazza from Srinagar. My question is to Dr. Binayak. It's a practical question that the current indication for GLP-1 analogs is BMI more than 30 and BMI more than 27 with one weight-associated comorbidity. As you said that the definition of this BMI has changed, especially in the Indian context. Should we start GLP-1 analogs in that category also, suppose BMI less than 27? And I have one more question, which is also one practical point. Like suppose a patient has lost significant amount of weight. Now he asks us that for how long should he continue this therapy? At some point you have to stop it. And now we have a data, then once you stop it, within 1 year, you gain the weight back. How can we handle that situation?
Uh, I think both of them are really wonderful questions. First of all, let me just correct this for the entire audience because I think I might have come across wrongly.
Correct.
The point is, there's been a white paper which was made by a group of obesity experts, so-called experts across India. And this suggested that in view of the data of cardiovascular disease in amongst Indians, MASLD amongst Indians, the BMI cutoff should be reduced to 23 to define obesity. And it's not overweight to define obesity. And as Dr. Hari Kumar, he was laughing at me because of this definition. But this is what has been suggested by this group of experts. But it has not been accepted. It has been suggested. Okay, so but there's a white paper. It's been published in Diabetes, Metabolic Syndrome, and Obesity Research and Reviews, and you can access it. It's free online, and you read through it. It's just a kind of suggestion that in view of the cardiovascular disease prevalent in India, it should be reduced to 23. The second question, I think, is a really very good question. First of all, I think we have to start thinking of obesity as a chronic disease in the sense that if somebody develops obesity, they will be having obesity for as long as they live. So, like diabetes, when we start somebody on a metformin, we tell them that you have to take them for life. You should ideally be suggesting to your patients that you do not stop a GLP-1 receptor agonist. But I do appreciate that these are very expensive molecules. So there has to be a cutoff mark as to how long minimally that you can take. And I don't think if somebody cannot afford 2 or 3 years of treatment, you should even try it, because I think it doesn't make sense. You will get the weight back on, but if you try it for 2 or 3 years, there's actually significant weight loss. And if after that, even if you gain 10%, so say someone goes from 100 to 80 and then they put on 10% of their body weight, they'll come up to only 88. So that is one way of looking at it. Other ways, there is like up titration of GLP-1, there is upcoming data on down titration of GLP-1. So instead of staying on 2.4, come down to 1.71 rather than completely stopping it in one go. So these are the two methodologies that you might want to use.
That once that
Yes, if
BMI
somebody has a BMI of less than 27 and has had a heart attack, I think you're well within your rights to give them
yeah,
semaglutide.
the BMI criteria is only for when you're using it for a obesity agent, anti-obesity. If it is for a anti-diabetic, it is irrespective of thing. Now, select and approval, it's a standalone cardiovascular protective agent. Okay, irrespective of BMI. There it is irrespective of BMI. Okay, so that is also important. But if you are using only for obesity, 30, obesity with comorbidity, 27. Okay, diabetes and cardiovascular, any other. Yeah, please.
I'm Dr. Sanjeev from my question to Dr. Sami. Sir, if some patient is doing very good with only GLP and sugar is well controlled, so does the patient will get the same benefit we are in GKPTS trial?
The pleiotropic benefit remains irrespective of whether the sugar is high or low.
Yes, sir.
So that's why Dr. Sinha shared a interesting article with me, which I don't see in any conferences. It's done by the stalwarts like Mogensen and by Itamar Raz and others. It's called the simple algorithm, which says that you have to use two types of drugs in managing diabetes. One are called glucose GLAs, glucose lowering agents. Another called DMDs, that is disease modifying drugs. So you must have at least one of them. So you must have at least a SGLT2 or GLP-1, and then control sugar using the other. So if you have on board a GLP-1 or SGLT2, you're protecting the organs, giving them early pleiotropic benefit. Even if sugars are high, take your time, bring them down slowly by using metformin, sulfonylureas, all the other drugs that we have. So the benefits will be there. The thing is, if I think that I'll keep the HbA1c at 9, I'll get all the benefits. Probably there will be some cardiovascular benefit, but then the eyes will conk off, the kidneys will go, they'll develop neuropathies. So from the
No, sir,
cardiovascular benefits,
HbA1c
fine,
is very good, and they are doing very good with single agent of GLP.
fine, absolutely.
Absolutely fine. No need to add
So if
metformin or
suppose they have 3 drugs, you add a GLP, and the sugars are going down below 6.5, cut down the other agents.
Thank you, sir.
Short-term obesity. There have been some strength you see when you try those. The thyroid comes control and you have what is our threshold? Like how many months or years of high BMI should the patient have when you to think of adding this who have no other comorbidities?
So I think that let's be very clear. All these trials have been done on a background of lifestyle management and intensive lifestyle management, and intensive behavioral therapy. So if you think that this is a temporary problem, I think the best way forward is to go in for lifestyle intervention rather than go in for something which is lifetime's commitment. If somebody wants to hang themselves, let them get hanged.
Take the opportunity.
No. Yeah, please.
Thank you to our speakers. Topic. I'd like to ask you, sir, one question. Sir, Dr. Vinayak, sir, you told me that that patient may have a paradox in a way that a patient is losing lean body mass but increasing the grip strength. How it is there, sir?
So I think again it must have been a shortcoming on my part. I actually showed an increase in lean body mass and reduction of body fat mass, which is in turn translates into an improved grip strength. So the semi lean study, it's in public domain. Have a read through it. It basically tells you that relative to the fat mass, the lean mass actually goes up, and therefore there is increase in grip strength. So it's not that they're losing lean mass.
Okay, sir.
We'll have the presentation by Dr. Anand for a few minutes on MASH, and then we'll move to further set of questions.
I think the reason why they have changed the terminology, initially it was NAFLD, then came as MAFLD. Indian apostles still continues to have as MAFLD instead of MASLD. But Americans, it is still 66% of the societies have agreed for MASLD, not 100%. But it is endorsed, and this is because metabolic factors are playing a role for development of fatty liver. So each one of any presence of fat in the presence of any single abnormal NCP, ATP criteria, then he is considered to have a fatty liver. And the presence of these parameters, this is not two metabolic risk factors. Apostle says two, but now it has been revised and is made that one parameter is sufficient. A diabetic with fat presence of fat is sufficient. Hypertension with presence of fat is sufficient. dyslipidemia presence of fat, and increased waist circumference presence of fat is considered as MASH LD. Lean, I concur with Dr. Here that BMI more than 23 may be considered as obesity. I am not aware of any trials, any studies being done, but for us, we see a lot of patients who come with BMI of 23 to 25 with having good amount of fat, and we struggle explaining them that you have to reduce weight because they say my BMI is normal. Why do you want me to lose weight? I'm not aware of any studies, but it would be a good thing to study on this aspect in Indian specialties. Non-invasive markers, as we discussed before, FIB4 is a very good marker. We also use EPRI, AST to platelet ratio. Or most EPRI is really easy to calculate. You can do it on your mobile as well. Just AST divided by normal limit of AST followed by platelet values. If it is more than 2, the patient has cirrhosis. Less than 1, the patient is normal. 1 to 2 is abnormal. FIB4 has been recommended by all the guidelines, but as we discussed before, 65% will be in the intermediate categories. So we would actually do a fibroscan for these patients. But any FIB4 more than 1.3, he should undergo a second test later on. In AIG, we also developed the AI model where, based on the CBP, LFT, and lipid profile, we can give a value of fat and fibrosis in the liver. We just need to enter the CBP, LFT, and lipid profile and HbA1c. That should be sufficient. And approach for MASH LD and MASH, the first thing is that and exercise, which is very difficult for all of us, including us. And there are many Instagram influencers which have been giving their own new diets daily. But the simple diet is avoiding sugars and the salt. And 5% of weight loss is required for fat reduction, 7% for inflammation, and 10% for fibrosis. We also try to add them on some other drugs with the availability of newer drugs. We have been using GLP-1 analogs in our limited domain. We have multiple trials in MASH as of now. So we have also started using retatrutide for these patients. Good. There is significant amount of improvement in the fat in these patients, reduction in the obesity, improvement in the MACE activities also, reduction in the MACE as well. And we have been using semaglutide. The tolerance in Indian population, I'm not sure of the endocrinologist perspective, but we usually do not go above 1.7. And there is reduction in the fat up to 30% of the patients lose obesity, definitely. And also steatohepatitis, that is inflammation is reduced by up to 60% of the patients lose the inflammation part. Fibrosis, when it comes to in clinical practice, it is around 10 to 15% as of now. But in the studies, they have quoted it to be 35%, but in our experience, it's around 30, 15, maximum to 20%. Definitely, there is other reductions as well, which will be taken up with.
So, benefits of semaglutide, MSLD attributed to its weight loss? No, not entirely. I think we have plenty of data which is addressing that, the histological resolution, the ALT response, the FAST score. Some of it is body weight reduction dependent, but a large portion of it is not. And also, even if you look at the fibrosis without worsening of MASH or the VCT or ELF score responders, only partially you can explain that with body weight reduction. And therefore, we know that people with a similar amount of weight reduction, people with MASH receiving semaglutide will have greater improvement in liver function, and liver related health will improve with semaglutide.
Dr. Samit.
Okay, so is entirely attributed to glycemic control? I don't think so. Otherwise, you wouldn't have an indication for non-diabetic population. But having said that, uncontrolled blood sugar can also cause increase in adiposity and can cause hepatic dysfunction. So in a type 2 diabetic patient in the background of MSLD, I think it's a double game. You have to have an improvement of blood sugar and have to have those medicines on board, which helps in reduction of MSLD. So we have seen this improvement in multiple trials that it's a double game. So you bring down the sugar as well as bring these drugs on board.
Yeah. Any questions from? Yeah, please.
Thank you, sir. Thank you, sir. So my question is to Dr. Anand, sir. So you have said that the terminology has been changed from NAFLD to MAFLD and then MASLD. Now, you also said that the metabolic disorders are causing fatty liver, or more precisely, it is vice versa.
We believe as a hepatologist that fat in the liver is a driver for metabolic dysfunction. but it's the other way around because I'm here. I have to say that it's the bi-directional.
Thank you, sir.
Tirzepatide versus semaglutide.
I think
Am I correct?
I think Shomit has shown you, as far as weight reduction is concerned, tirzepatide is definitely superior. And the only other indication where tirzepatide definitely has a higher indication is obstructive sleep apnea. In all other areas, whether it be heart failure, whether it be cardiovascular disease, whether it be MASLD, semaglutide has more data. And I think he also showed you that, this weight loss of around 3.5%, after that, 3.5 kilograms, after that, the benefits of cardiovascular disease kind of plateau, which is why you did not see the benefit that we would have expected with surmount CVOT that you see.
No.
Yes. Yes. So say I'll give you an example. So that you have a 25-year-old man who's morbidly obese and does not have any other risk factors like liver disease or cardiovascular disease. Please, by all means, that is an indication for using tirzepatide, whether you're just focusing just on weight loss. But if that person has, say, it's a 35-year-old man who's had a heart attack, it's going to be semaglutide.
Dr. AK Singh, your comments?
I think one
You're
more
sitting
thing.
quiet.
When these guidelines came, I think simultaneously the tirzepatide, MSLD, I think it was called Synergy, the trial which was also published, that was not taken into account. So if it comes, it is taken into account, whether it will still remain as a Class B indication and to a Class A of semaglutide, that time will tell you. But if that has been taken into account, then that is an interesting development where we see that if it's entirely MSLD focused, then definitely as we stand today, the drug of choice is the semaglutide. We still don't have the recommendations telling you to give a tirzepatide for greater weight loss over a semaglutide.
Dr. AK, you want to add?
I'm sure previous speakers must have spoke on both the molecule and compared. So I fully agree with the speakers that okay, for obesity part, all they have discussed that yes, tirzepatide does have additional potential of lowering body weight and perhaps HbA1c as well. But when it comes to other risk factors, barring obstructive sleep apnea, which semaglutide doesn't have any trial exclusively on that. Semaglutide scores over tirzepatide in terms of CV space, heart failure, MSLD. Remember, Synergy NASH is a phase 2 trial. So tirzepatide does have MSLD data, but that is on a very small patient, 48 patients, in 2 arm. That is a phase 2 trial. But Synergy NASH outcome is currently under progress. In future, tirzepatide might get the similar data as of semaglutide. But at the moment, as all the speakers saying, semaglutide has got better MSLD data because that's a phase 3 trial with a larger number of patients. So choice is semaglutide for heart disease, for heart failure, for MSLD. For additional weight loss, tirzepatide scores.
Thank you. Any other question, comment?
Why some patients can't operate beyond 5%, sir, even the
Yeah.
tirzepatide also. And
Non-responders.
nausea and vomiting, and even after the
Non-responders.
So there was one trial called the Victoria trial, in which they looked at 158 attributes which normally can explain why you are getting all those cardiovascular benefits and responders and non-responders. So especially with subcutaneous injection, there are 35 receptors with which the molecule has to compete. There are 35 different molecules with each like in insulin you have a fat. It has to go into the fat depot and then it goes from a hexamer to a monomer, etc. Here there are 35. Now those are determined also genetically by from individual to individual who expresses how much of that. And since the number of attributes which are responsible for the action of the molecule is 35 under the skin, that is why this is one molecule which has the highest non-responder rate among lifestyle and sulfonylureas and metformin and everything. They found that even lifestyle has a failure rate of 20%. Metformin has a failure rate of around 15 to 20%. Not from GI side effect. They don't respond. But GLP-1 has the highest non-responder rate of around 30 to 35% because it has more attributes to play with in the subcutaneous space. I can't say about what happens with orally. I have no idea. That I have to read through.
And sir, regarding the retinopathy part, if some patient is already having some sort of retinopathy and he's having a CAD already and already on medication, so do we need to consider GLP for these patients for cardiovascular benefit?
So these are all clinical decision making. You have to process the pros and the cons. I think if somebody has macular edema or somebody has proliferative diabetic retinopathy, do not prescribe semaglutide. But if somebody has just a mild non-proliferative diabetic retinopathy, you can keep the patient under regular observation and definitely give him the cardiovascular benefit. No harm in doing that.
Yeah, thank you, sir.
And as of now, we don't have any kind of strict data to suggest that there is worsening of retinopathy. It is not something that has been seen. Ideally, yes. Well, every diabetic patient should have a retinopathy check in any case.
Another question on lean mass. I think that you rightly pointed out the percentage or the proportion of lean mass to body fat is changing. However, do you think that because we're considering these agents for long term, we are moving towards from BMI to waist height circumference, but do you also think it is required that we track lean mass, muscle mass, because we're thinking of 12 months, 24 months? How's the skeletal muscle mass like BIA, for instance, because DEXA can be challenging? And also your thoughts on agents such as bimagrumab, the monoclonal antibody which was studied, but somehow it was withdrawn. Any agents in the pipeline for muscle retention?
There are other maps coming up. Looking
Your
into
thoughts
it.
on these?
And monitoring skeletal muscle mass should be done by two different methods. Easiest method is MAMC, which is mid-arm, the muscle circumference. That is one easy way of doing it. And hand grip strength. So these are easy way of doing it. The other, if you have the luxury of having a body fat analyzer, you can use that because then you have three bars. First one is your body weight. Second is the skeletal muscle mass, SSM. Third is the body fat percentage. It should be a straight line. If it is C-shaped curve, it means that your skeletal muscle is low and the fat is increasing. So suppose someone is losing their fat, you can monitor with the BSA very beautifully. So they're losing their fat, so the body weight is going down, but the skeletal muscle mass remains the same or is also equally. So the C remains the same even if the patient is losing weight, which means we are not doing a good job. There are a lot of mass loss which is contributing to the weight loss. The most difficult thing and very easy to see from your BSA is the visceral adipocytes. I have patients losing 10, 15 kilograms with not even 1% reduction in the visceral adipose tissue. So probably this patient is getting a lot of cosmetic weight loss, but is not getting the actual visceral weight loss that we are looking into it. So if you have the luxury of those machines, you can play around much better, I think. Or you can
Yep.
use a skin fold. I think what is called the tricep, yeah,
Calipers.
Yeah, calipers can be.
So, with all due respects to the chair,
1 second. One
with all due
second, sir.
respects
We'll
to the
take your
chair,
question. Yeah, please.
with all due respects to the chair and the speakers, I'm Dr. Radha from Malaysia. I'm a principal investigator for Sustain 6 and Pioneer 6. And when we did the study, I appreciate the question that came about wanting to start semaglutide on patients with high cardiovascular risk, despite them having retinopathy. So when we did the study, we were instructed that when the patient's HbA1c is pretty well controlled, you should de-escalate your insulin by at least 20%. You should also halve the dose of your sulfonylurea. What we did not expect from semaglutide in Sustain 6 was that even with the first dose, we had patients getting hypoglycemic unconsciousness. I had to report that as a serious adverse event. So this is very unusual. But even with the first dose, especially in elderly patients, you can get hypoglycemic unawareness. So we have to be very cautious about this. And I think it's a slow titration because what we attributed the worsening of the retinopathy was due to a sudden drop in the glucose. So take it slow and steady. Don't escalate too fast. I think we are here to help our patients get the benefit out of the semaglutide, but we are also here to make sure that they can receive this therapy safely. Thank you.
Absolutely. Absolutely.
So, Dr. Singh, could first dose hypoglycemia be attributed to an allergic sort of reaction? Otherwise, I can't explain why there should be an acute hypoglycemia. Allergic, I think.
No. I'll just say, even if metformin, there are data to say 0.3 to 0.5% hypoglycemia. In trial, if a person feels hypoglycemia, they are recording it as a SAE. The moment it gets in clocked, it comes as metformin shows this much percentage. You may not have it is so that is how all so-called non-hypoglycemic agents also will have some hypoglycemia recorded.
Yeah, true. Even in UKPDS, metformin arm, 6% of the people in UKPDS on metformin arm required hospitalization due to
Correct.
hypoglycemia,
Absolutely.
knowing well that metformin doesn't cause hypoglycemia.
Absolutely.
And later on, even in Indian DPP-4 trial, done by Dr. Ramchandran, the entire plan was to start with a 500 milligram twice daily, but he has to lower it to 250 milligram twice daily because
Correct.
45% developed hypoglycemia. So that is example, and I agree with doctor from Malaysia that when he said that some patients develop hypoglycemia, this is the reason as to why after the sustain 6, remember during sustain 6, the dose of semaglutide to initiate was 0.5 milligram. But today we are not starting with 0.5 milligram. We are starting with 0.25 milligram. So that from the sustain 6, we learned a lot of a story. That was the first trial actually looking into the CV outcome. And there was a 1.5% HbA1c drop with semaglutide, in mean reduction, despite a glycemic equivalent. So you tried your best to have a similar HbA1c in both arms, yet semaglutide arm had an additional 1.5. Summit did one mediation analysis and suggested that whether this CV benefit is related to cardiovascular HbA1c drop in those trials. And he did so that it is partially related to the HbA1c reduction. So
Correct.
yes, sometimes hypoglycemia happens, which is unexplained. Perhaps we didn't know why it was happening, whether it is hypersensitivity or because of not reduction in the insulin or sulfonylurea dose. But it was seen with many drugs, including metformin.
Absolutely. We'll have
Uncontrolled hyperglycemia, or if somebody has high blood glucose, they can get retinopathy. I don't think it has been shown. As of now, I think we are just waiting to find out more of this.
And Dr. Sinha, one point I would like to make it. Eye doesn't have a GLP-1 receptor. The entire structure of eye, starting from anterior compartment to the posterior compartment, there is a zero GLP-1 receptor in retina. So day before yesterday, there was one paper came in JAMA. You can see Eric Topol posted on Twitter that there is increase in NION. The percentage, prevalence is 0.03%. There are now 10 papers with semaglutide and tirzepatide on NION. 5 suggested increase, 5 suggested decrease. So these are retrospective data from a US database. Please remember, focus trial is already ongoing since 2019. We are now 6-7 years into the focus trial. Had there been any signals of increase in eye problem with semaglutide, this trial would have stopped by now by the data safety monitoring board. So we presume that this is not directly related to semaglutide or GLP-1 as such, because eye doesn't have any GLP-1 structure. Something might be underpinning behind this increase in perhaps hypoglycemia.
Yep.
That is one part. So we exactly don't know, but the good news is that focus trial is on for past 6 years and the trial has not been stopped. Had there been any signals of increase in retinopathy, etc., the trial would have been
it
stopped
is
by now.
But I
it
think
is
FDA gave a very clear statement
Correct.
that it is entirely due to the rapidity of glucose lowering that
absolutely.
your retinopathy might progress. It's
And
not
if
directly due to the
right.
molecule per se.
And even no
It
regulator
is
says that you need to mandatorily check eye before starting GLP-1.
correct.
Even someone develops retinopathy during GLP-1, you are not supposed to stop the drug. So if you look at the
This
recommendation, although it's pragmatic that we look at the retina, if there is a proliferative DR, we do not start GLP-1. That's a very wise decision as a clinician. But otherwise, on evidence-wise or regulatory-wise, nobody suggests us to stop this.
Probably it's prudent to stop pioglitazone.
it is mandatory to stop. Dr. Kalyan.
I'll just elaborate a bit on the muscle strength that you have said. So any strategy to lose body weight will result in reduction in muscle
Correct.
mass. Now, so we have to look at say DPP4 inhibitors. They would say that initially it is likely to be cardioprotective, but when you have the CVOT, there was nothing. So you have to look at muscle strength rather than the muscle mass. This is my viewpoint. because there is a lot of animal data with GLP-1 receptor agonists, which suggests that the intramuscular fat is reduced to a significant extent. That is good animal data, some human studies as well. So you're reducing. So if you take this much of muscle and that is reduced, part of it will be fat inside the muscle as well. So you have to look at muscle strength, not the muscle mass. That is what I feel. And so in the SEMA lean study, if I'm not mistaken, there was there was increase in hand grip strength. It's very simple to do muscle strength. As Shomit has said, muscle strength with the hand grip dynamometer and get up and go test. So you can sit up and stand up 10, 20 times, how much time you're taking, how much you're taking to walk 6 meters. These are all muscle strength exercises. And if you do that, there's actually improvement, even though the muscle mass technically seems to be less.
In the current era of assessment, there is no way you can assess that only the muscle or the fat is losing. So whatever the trials are doing, and any amount of weight loss, even the best of the lifestyle, you will lose a portion of muscle also. But with improved functioning, with less, I mean, it is something like 500 glucose person is more fatigued, but 100 glucose, the person is more energetic. So that's the same analogy which can work.
Because I think the data also shows that like many patients comes and says, oh, we will do a lifestyle, a very low lead diet, very low energy diet and lose weight. As a matter of fact, skeletal muscle loss is much more with
Correct.
a very low calorie diet than even with a GLP-1. So, and one more question was raised about what happens to catch up weight when you lose them. Again, there's a Lancet data no one talks about. I don't know why. There's a 3-arm trial with liraglutide. That time, I think 3 milligrams was used. One arm had just lifestyle for 1 year. One arm had lifestyle plus liraglutide for 1 year. Third arm had only liraglutide without lifestyle for 1 year. Then they were discontinued and monitored for the next 1 year. The worst performer was who were taking only liraglutide, even worse than lifestyle. But those who had lira plus lifestyle and continued with the lifestyle for the next 1 year and took away the liraglutide actually maintained their weight. So it's not necessarily that you just lose the drug and you start gaining weight. That panic is also not required. So if you're not putting on board a diet and you think you're giving someone a GLP-1 and you're just going to lose weight, like that's not going to happen. You can't even maintain that when you withdraw the drug after some time.
I think we had a wonderful discussion. The bottom line is have a good lifestyle, use the available drugs, you will do maximum benefit to the patients. Correct? I think it is.
Should have exercise more in that case because many of patients get to cardio protective exercises or cardio because they are running or jogging.
You
Since the, again, 2006 ADA recommendation, no one probably reads the lifestyle part of the topic. Everyone will jump to the pharmacotherapy part. The lifestyle part has been consistent throughout 5 days of aerobic exercise, 3 days of resistance training. It's always been there.
it is both are important. You cannot do it in isolation. And he showed beautifully you cannot protect heart and leave the kidney aside or liver aside. Okay. I'm sure you have understood that. Thanks to all the panelists.